Hi, this is Andrew Wolf. In this video, I'm going to be talking about the treatment of sickle cell disease. So with sickle cell disease, it is an inherited genetic disorder. There are two possibilities that we have for managing sickle cell disease, and one is chronic management. And I'll talk about chronic management in a minute. And the other is cure. Now, you might be surprised to hear me say this because when you think about an inherited genetic condition, how could that be curable? Well, the genetic condition is a condition that occurs in the cells that are precursors to erythrocytes, or red blood cells. So these are the erythropoietic cells, and they're the ones that contain, well, all cells have the genetic material, but the gene is really only expressed in the erythropoietic stem cells. So this, remember in one of my earlier videos I talked about the 11th chromosome, and the 11th, one part of the 11th chromosome contains the gene for the beta chain of hemoglobin. And so hemoglobin is being produced by this gene within an erythropoietic stem cell, and that's what creates the hemoglobin within the mature stem cells, right? So with patients with sickle cell disease, they don't have the normal hemoglobin A, they have a different version called hemoglobin S. Right, and hemoglobin S again is caused by this genetic defect or genetic mutation in the 11th chromosome. So how do we cure this disorder? Well, what we do is we do a hematologic stem cell transplant. So we actually give a person a treatment to remove their hematologic stem cells, including their erythropoietic stem cells, so both the stem cells that create red blood cells as well as the stem cells that create white blood cells, and we replace them with a healthy donor. Okay, so the cure is by hematopoietic stem cell transplant. And so we do this by giving the sickle cell patient a medication that, our bones are filled with marrow, and the bone marrow is where our hematopoietic stem cells live, and this is where our erythropoietic stem cells live, and where the immature red blood cells are transformed into mature red blood cells and put out into the bloodstream. So what happens in hematopoietic stem cell transplant is we actually give the patient a medication, chemotherapy, that ablates their marrow. And then we get some hematopoietic stem cells from a healthy donor. And in this case, in the case of sickle cell disease, the healthy donor has to be a sibling, and the sibling has to have closely matched genetics, and the sibling also has to not have sickle cell disease. So we take these stem cells and we insert them in through an IV into the bloodstream of the sickle cell patient, and this allows new marrow to grow, new healthy marrow to grow, and this new healthy marrow has erythropoietic stem cells that create hemoglobin A instead of hemoglobin S. Okay, so we have new healthy erythrocytes with hemoglobin A. All right, now this is a very risky procedure because the mortality rate can be as high, is reported to be between 7 and 20% just from the procedure itself. The person has no white blood cell function for several weeks after the transplant and are prone to infections, and also the white blood cells from the donor can actually attack the patient's entire body as non-self and can attack the body. And this is called graft-versus-host disease, and this can cause mortality as well. So this is something to consider very carefully, and it's only available to patients that have healthy siblings. So about 25% of sickle cell patients can receive. So cure is an option that's only available to a minority of patients. So for the rest of sickle cell patients, we need to engage in chronic management. So chronic management involves preventing vaso-occlusive crisis, treating these crises when they occur, preventing infection, preventing infection. Infection is actually the #1 cause of mortality in sickle cell patients, so this is very important. Then we have treating anemia, because remember, the sickled red blood cells are much more likely to break down, and this can cause chronic anemia. And then we have managing chronic complications. And these complications can include stroke, pulmonary hypertension, and others, and I'm going to talk about those in a separate video. So I want to talk first about preventing vaso-occlusive crises. There's sort of two mainstays of treatment that can accomplish this. The first is a medication called hydroxyurea. Now, the way hydroxyurea works is it replaces some of the hemoglobin S in the erythrocyte with fetal hemoglobin, or hemoglobin F. So if we imagine the hemoglobin S here is the purple one, it actually replaces some of that with hemoglobin F. And by decreasing the concentration of hemoglobin S in the erythrocyte, it decreases the chance that the hemoglobin S can polymerize and cause sickling. Now, unfortunately, hydroxyurea affects all bone marrow cells and actually is a bone marrow suppressant, and it actually, giving hydroxyurea significantly increases the chance of infection. So it's something that you need to consider very carefully, and you need to even increase your prevention of infection, your modalities for preventing infection even more. Now, the second part of preventing vaso-occlusive crises is chronic transfusions. Now, again, chronic transfusions works in some way similar to hydroxyurea, because it decreases the concentration of red blood cells that have hemoglobin S in them. Because if we've got some erythrocytes, with a sickle cell patient, all erythrocytes are filled with 100% hemoglobin F, or nearly 100%, 97% or so. But if we give chronic transfusions, some of these red blood cells are going to have nice, healthy hemoglobin from the donor. And this decreases the number of cells that can sickle, and this will decrease the number of crises that people have. Chronic transfusions are useful in patients that have had significant complications, particularly patients that are at high risk for stroke, because they've had transcranial Dopplers that have shown some abnormalities that show that a stroke could happen anytime in the near future, or patients that have had strokes in the past. So the modality is to provide a transfusion about 8 to 10 times per year, so every 1 to 2 months. And that will decrease the number of red blood cells that can sickle, and that decreases the number of vaso-occlusive crises. Okay, so in my next video, I'm going to talk about how to treat crises when they occur, how to prevent infections, how to treat anemia, how to both treat anemia and prevent anemia, and I'm going to talk about managing complications of vaso-occlusive crises and the chronic complications of sickle cell anemia. See you in the next video.